Question 1. A patient in the ICU post-cardiac surgery suddenly develops hypotension, MAP 55 mm of mercury, tachycardia, HR 125 BPM, and decreased urine output, 10 ml/HR. Central venous pressure, CVP, is 18 mm of mercury, and pulmonary artery occlusion pressure, PAOP, is 22 mm of mercury. Which intervention should the nurse anticipate first? A. Administer a rapid intravenous fluid bolus. B. Prepare for pericardiocentesis. C. Initiate a norepinephrine infusion. D. Administer a diuretic such as furosemide. Answer B. Prepare for pericardiocentesis. This question tests your ability to recognize and prioritize interventions for cardiac tamponade, especially in a post-operative cardiac surgery patient. The keywords here are post-cardiac surgery, hypotension, tachycardia, decreased urine output, and critically, elevated CVP and PAOP. These findings, particularly the high filling pressures, CVP and PAOP, indicate that the heart cannot effectively pump blood despite adequate volume, suggesting compression of the heart, often due to fluid accumulation in the pericardial sac, cardiac tamponade. Pericardiocentesis is the priority intervention to relieve the pressure, as giving fluids or vasopressors would not address the underlying mechanical compression and could potentially worsen the patient's condition. Question 2. A 68-year-old patient with ARDS on mechanical ventilation with a PEEP of 15 cmH2O suddenly develops acute onset hypotension, tracheal deviation to the right, and absent breath sounds on the left. What is the immediate nursing intervention? A. Increase the fraction of inspired oxygen, FiO2, to 1:0. B. Administer an intravenous fluid bolus. C. Prepare for emergent needle decompression of the left chest. D. Suction the endotracheal tube to ensure patency. Answer C. Prepare for emergent needle decompression of the left chest. This question evaluates your critical assessment skills and knowledge of life-threatening respiratory emergencies in a ventilated patient. The keywords ARDS, PEEP of 15 cmH2O, sudden acute onset hypotension, tracheal deviation to the right, and absent breath sounds on the left are classic indicators of attention pneumothorax. Attention pneumothorax is a medical emergency where air accumulates in the pleural space under pressure, collapsing the lung and pushing the mediastinum, including the trachea and heart, to the opposite side, compromising venous return and cardiac output. The immediate, life-saving intervention is emergent needle decompression of the affected, left, chest to relieve the pressure. Question 3. A nurse is reviewing arterial blood gas, ABG, results for a patient with diabetic ketoacidosis, DKA, pH 7:18, PaCO 2 28 mm of mercury, HCO3 12 milliequivalent/L, PaO 2 90 mm of mercury. Which primary acid-base imbalance does this indicate? A. Metabolic alkalosis with partial respiratory compensation. B. Respiratory acidosis with full metabolic compensation. C. Metabolic acidosis with partial respiratory compensation. D. Respiratory alkalosis with partial metabolic compensation. Answer C. Metabolic acidosis with partial respiratory compensation. This question assesses your ability to interpret ABG results to determine the primary acid-base disturbance and compensatory mechanisms. The pH of 7:18 is acidic, the bicarbonate, HCO3, of 12 milliequivalent/L is significantly low, and the PaCO 2 of 28 mm of mercury is also low. A low pH and low HCO3 indicate a primary metabolic acidosis, which is consistent with DKA. The low PaCO2 shows that the respiratory system is attempting to compensate by increasing the respiratory rate to blow off CO2, a respiratory alkalosis, but since the pH is still abnormal, the compensation is only partial. Recognizing these parameters allows for appropriate management of the underlying condition. Question 4. A patient with a severe traumatic brain injury, TBI, exhibits decorticate posturing. The nurse understands this finding indicates damage to which area of the brain? A. Cerebellum. B. Brainstem, midbrain or pons. C. Cerebral hemispheres, internal capsule, or thalamus. D. Spinal cord. Answer, C. Cerebral hemispheres, internal capsule, or thalamus. This question tests your knowledge of neurological assessment and the anatomical significance of posturing in brain injury. Decorticate posturing, characterized by abnormal flexion of the arms and extension of the legs, is a specific neurological sign. It typically indicates damage to the cerebral hemispheres, internal capsule, or thalamus, signifying a lesion above the red nucleus in the midbrain. This is an important indicator of severe brain injury, requiring close monitoring for any changes, as a progression to decerebrate posturing would suggest more extensive and lower brainstem damage with a poorer prognosis. Question 5. A 58-year-old patient is admitted with acute coronary syndrome. On the ECG monitor, the nurse observes T-wave inversion and ST segment depression in leads V2-V4. Which area of the heart is most likely affected? A. Inferior wall. B. Lateral wall. C. Anterior wall. D. Posterior wall. Answer, C. Anterior wall. This question requires knowledge of ECG lead placement and their corresponding anatomical areas of the heart, specifically in the context of acute coronary syndrome. T-wave inversion and ST segment depression in leads V2-V4 are classic ECG changes indicating myocardial ischemia or infarction affecting the anterior wall of the heart. These leads look directly at the front part of the heart, which is primarily supplied by the left anterior descending, L80, coronary artery. Understanding these lead associations is crucial for identifying the location of cardiac injury and anticipating potential complications. Question 6. A patient with syndrome of inappropriate antidiuretic hormone, SIADH, is critically ill. Which laboratory value is the nurse most concerned about? A. Serum potassium 3, 8 milliequivalent/L. B. Serum sodium 118 milliequivalent/L. C. Blood glucose 120 milligrams per deciliter. D. Serum creatinine 1, 0 mg/dl. Answer, B. Serum sodium 118 milliequivalent/L. This question focuses on recognizing critical electrolyte imbalances associated with SIADH. SIADH is characterized by excessive release of antidiuretic hormone, ADH, leading to water retention and dilutional hyponatremia. A serum sodium level of 118 milliequivalent/L is severely low, normal 135 to 145 milliequivalent/L, and is the most concerning finding. Severe hyponatremia can cause cerebral edema, seizures, and increased intracranial pressure due to osmotic fluid shifts into brain cells. Prompt intervention, often involving fluid restriction and careful sodium correction, is vital to prevent life-threatening neurological complications. Question 7. A patient in acute kidney injury requires continuous renal replacement therapy, CRRT. The nurse notes the patient's activated clotting time, ACT, is 250 seconds, therapeutic range 180 to 220 seconds. What is the appropriate nursing action? A. Increase the heparin infusion rate. B. Decrease the heparin infusion rate. C. Administer protamine sulfate. D. Flush the CRRT circuit with normal saline. Answer B. Decrease the heparin infusion rate. This question tests your understanding of anticoagulation management during CRRT. The activated clotting time, ACT, measures the blood's clotting time, which is crucial for monitoring heparin's effect and preventing clotting within the CRRT circuit. An ACT of 250 seconds is above the therapeutic range of 180 to 220 seconds, indicating that the patient is over-anticoagulated and at an increased risk for bleeding. Therefore, the nurse should decrease the heparin infusion rate to bring the ACT back into the desired therapeutic range, ensuring patient safety while maintaining circuit patency. Question 8. A patient with acute pancreatitis develops severe abdominal pain, distension, and absent bowel sounds. The nurse notes a Cullen's sign, periumbilical ecchymosis, and Gray-Turner's sign, flank ecchymosis. These findings suggest which severe complication? A. Pancreatic ascites. B. Pancreatic pseudocyst. C. Hemorrhagic pancreatitis. D. Pancreatic abscess. Answer C. Hemorrhagic pancreatitis. This question assesses your ability to recognize specific clinical signs indicative of a severe complication of acute pancreatitis. Cullen's sign, bluish discoloration around the umbilicus, and Gray-Turner's sign, bluish discoloration in the flanks, are hallmark indicators of retroperitoneal bleeding. This bleeding is characteristic of severe hemorrhagic pancreatitis, a life-threatening complication where pancreatic enzymes leak into surrounding tissues, causing necrosis and hemorrhage. These signs warrant immediate attention for aggressive supportive care and monitoring for hypovolemic shock. Question 9. A patient with disseminated intravascular coagulation, DIC, has new orders for a blood transfusion. The nurse prioritizes which component to administer first. A. Packed red blood cells, PRBCs, for anemia. B. Fresh frozen plasma, FFP, for coagulation factor replacement. C. Platelets for thrombocytopenia. D. Cryoprecipitate for fibrinogen replacement. Answer B. Fresh frozen plasma, FFP, for coagulation factor replacement. This question evaluates your understanding of blood product prioritization in the complex condition of disseminated intravascular coagulation, DIC. DIC involves widespread activation of the coagulation system, leading to both excessive clotting and severe depletion of clotting factors and platelets, resulting in hemorrhage. While all listed components may eventually be needed, fresh frozen plasma, FFP, provides a broad spectrum of coagulation factors. Replacing these factors is often the most immediate priority to address the underlying coagulopathy and control active bleeding, which can be life-threatening in DIC. Question 10. A 70-year-old patient presents with new-onset altered mental status, fever, leukocytosis, and hypotension. The lactate level is 4.5 mol/L. The nurse recognizes these findings as indicative of which stage of sepsis? A. SIRS, systemic inflammatory response syndrome. B. Sepsis. C. Septic shock. D. Multiple organ dysfunction syndrome, MODS. Answer C. Septic shock. This question tests your ability to differentiate the stages of sepsis based on clinical and laboratory findings. The patient presents with signs of infection, fever, leukocytosis, and systemic inflammatory response, altered mental status, combined with hypotension and an elevated lactate level, 4.5 mol/L. Hypotension requiring vasopressors to maintain MAP greater than or equal to 65 mm of mercury and a serum lactate level greater than 2 millimoles per liter despite adequate fluid resuscitation are the defining criteria for septic shock. The presented symptoms and lactate level strongly indicate that the patient is in septic shock, a severe and life-threatening form of sepsis. Question 11. A patient presenting to the ED with acute chest pain and ST segment elevation in leads 2, 3, and AVF is diagnosed with an inferior wall myocardial infarction. The nurse should be most vigilant for which complication? A. Pulmonary edema. B. Left ventricular failure. C. Bradycardia and heart block. D. Ventricular fibrillation. Answer: C. Bradycardia and heart block. This question focuses on specific complications associated with different types of myocardial infarction. ST segment elevation in leads 2, 3, and AVF indicates an inferior wall myocardial infarction. The right coronary artery, which typically supplies the inferior wall, also supplies the AV node in most individuals. Therefore, damage to this area often disrupts the heart's electrical conduction, leading to bradycardia and various degrees of heart block. While other complications are possible with any MI, bradycardia and heart blocks are particularly common in inferior MIs and require close monitoring and potential intervention, e.g., atropine, pacing. Question 12. A patient with a nasogastric tube to low intermittent suction for several days complains of muscle cramps and weakness. ECG shows prominent U waves. Which electrolyte imbalance is most likely causing these signs? A. Hyperkalemia. B. Hypocalcemia. C. Hypomagnesemia. D. Hypokalemia. Answer: D. Hypokalemia. This question assesses your ability to link clinical symptoms and ECG findings to specific electrolyte imbalances. Prolonged nasogastric tube suctioning leads to the loss of gastric fluid, which is rich in potassium. The patient's symptoms of muscle cramps and weakness, combined with the classic ECG finding of prominent U waves, are highly indicative of hypokalemia, low potassium. Hypokalemia can also cause cardiac dysrhythmias and paralytic ileus. Prompt recognition and potassium replacement are essential to prevent potentially life-threatening cardiac complications. Question 13. A critical care nurse is caring for a patient whose family is demanding aggressive interventions, despite the patient's clear advance directive requesting comfort care only. The medical team is hesitant to override the family's wishes due to their distress. Which ethical principle is primarily in conflict here? A. Beneficence. B. Non-maleficence. C. Autonomy. D. Justice. Answer: C. Autonomy. This question evaluates your understanding of ethical principles in end-of-life care. The primary ethical principle in conflict here is autonomy, which refers to the patient's right to make decisions about their own health care. The patient's clear advance directive explicitly states their wishes for comfort care. While the family's distress is important, overriding a competent patient's documented wishes for treatment undermines their autonomous decision-making. The healthcare team's ethical obligation is to uphold the patient's autonomy, even when it conflicts with family desires, by advocating for the patient's expressed wishes. Question 14. A patient admitted with a fractured femur develops sudden onset of dyspnea, petechiae on the chest and axilla, and confusion. What is the most likely diagnosis? A. Pulmonary embolism. B. Acute respiratory distress syndrome, ARDS. C. Fat embolism syndrome. D. Pneumonia. Answer, C. Fat embolism syndrome. This question tests your ability to recognize the classic clinical presentation of fat embolism syndrome. The key clues are a recent long bone fracture, fractured femur, followed by the classic triad of symptoms: sudden onset of respiratory distress, dyspnea, neurological changes, confusion, and a petechial rash on the chest and axilla. This syndrome occurs when fat globules from the bone marrow enter the bloodstream and lodge in the capillaries, typically of the lungs and brain. Prompt recognition is vital for supportive care, as there is no specific treatment beyond symptom management. Question 15. A nurse is evaluating a patient with a suspected overdose of salicylates. Initial ABGs show pH 7, 50, PaCO2 25 mm of mercury, HCO3 20 milliequivalent/L. This pattern most likely represents A. Compensated metabolic alkalosis. B. Mixed respiratory and metabolic alkalosis. C. Mixed respiratory alkalosis and metabolic acidosis. D. Compensated respiratory acidosis. Answer, C. Mixed respiratory alkalosis and metabolic acidosis. This question challenges your ability to interpret complex ABG findings, especially in the context of salicylate overdose. The pH of 7.50 indicates alkalemia. The PaCO2 of 25 mm of mercury is low, suggesting a primary respiratory alkalosis due to salicylate-induced respiratory center stimulation. However, the HCO3 of 20 milliequivalent/L is also low, indicating a metabolic acidosis. Salicylate toxicity causes a mixed disorder, initial respiratory alkalosis followed by or concurrent with a metabolic acidosis, due to lactic acid accumulation. Therefore, these ABG results represent a mixed respiratory alkalosis and metabolic acidosis. Question 16. The nurse is caring for a patient in hypovolemic shock. Which hemodynamic parameter indicates the most immediate need for further fluid resuscitation? A. Central venous pressure, CVP, of 4 mm of mercury. B. Mean arterial pressure, MAP, of 68 mm of mercury. C. Pulmonary artery occlusion pressure, PAOP, of 10 mm of mercury. D. Cardiac index, CI, of 2.5L/min/M2. Answer, A. Central venous pressure, CVP, of 4 mm of mercury. This question assesses your understanding of hemodynamic monitoring in hypovolemic shock and the most direct indicator for fluid needs. In hypovolemic shock, the primary issue is a decreased circulating blood volume, leading to reduced preload. A central venous pressure, CVP, of 4 mm of mercury, normal 2 to 6 mm of mercury, especially in the context of shock, indicates low right-sided preload, signifying inadequate intravascular volume. While a MAP of 68 mm of mercury is borderline and the CI of 2.5L/min/M2 is within a normal range, but could be relatively low in shock, a CVP at the lower end or below normal directly suggests the need for further fluid resuscitation to optimize cardiac preload and improve cardiac output. Question 17. A patient with status asthmaticus is intubated and mechanically ventilated. The high-pressure alarm frequently sounds, and the nurse observes very prolonged expiratory phases. The patient's breath sounds are diminished bilaterally with distant wheezing. What is the priority nursing intervention? A. Increase the sedation and administer a neuromuscular blocking agent. B. Suction the endotracheal tube. C. Administer a bronchodilator via nebulizer. D. Assess for autopeep and consider decreasing respiratory rate or tidal volume. Answer, D. Assess for auto-PEEP and consider decreasing respiratory rate or tidal volume. This question focuses on managing severe status asthmaticus in a mechanically ventilated patient. The keywords status asthmaticus, high pressure alarm, prolonged expiratory phases, and diminished breath sounds/wheezing strongly suggest dynamic hyperinflation and auto-PEEP, intrinsic PEEP. Air trapping in the lungs leads to increased intrathoracic pressure, which can cause barotrauma, hypotension, and impaired gas exchange. The priority is to address this air trapping by allowing more time for exhalation, which can be achieved by decreasing the respiratory rate or tidal volume, or by increasing the inspiratory to expiratory, i.e., ratio, thereby reducing auto-PEEP and associated complications. Question 18. A patient post-cardiac arrest is receiving therapeutic hypothermia at 33 degrees Celsius. The nurse notes a serum potassium level of 2.9 milliequivalent/L. What is the most appropriate action? A. Administer a rapid 4-potassium bolus. B. Initiate a continuous potassium infusion with close monitoring. C. Anticipate a return to normal potassium levels upon rewarming. D. Administer a loop diuretic to balance electrolytes. Answer: B. Initiate a continuous potassium infusion with close monitoring. This question tests your knowledge of electrolyte management during therapeutic hypothermia. Hypokalemia, low potassium, indicated by a serum potassium of 2.9 milliequivalent/L, is a common and anticipated complication of therapeutic hypothermia because potassium shifts into the cells as the body cools. While potassium levels may indeed normalize or even rise upon rewarming, the current hypokalemia is significant and can lead to dangerous cardiac dysrhythmias. Therefore, the most appropriate and safest action is to initiate a continuous potassium infusion with close monitoring, allowing for gradual correction and preventing a sudden hyperkalemic overshoot during rewarming. Question 19. A critical care nurse is managing a patient with rhabdomyolysis presenting with myoglobinuria. Which intervention is the highest priority to prevent acute kidney injury? A. Administer sodium bicarbonate to alkalinize the urine. B. Initiate aggressive intravenous fluid administration. C. Administer mannitol to promote diuresis. D. Restrict protein intake to reduce renal workload. Answer: B. Initiate aggressive intravenous fluid administration. This question assesses your understanding of the highest priority intervention for preventing acute kidney injury in rhabdomyolysis. In rhabdomyolysis, muscle breakdown releases myoglobin, which is nephrotoxic, especially in concentrated, acidic urine. The highest priority is aggressive intravenous fluid administration to ensure adequate urine output and dilute the myoglobin, effectively flushing it from the renal tubules and maintaining renal perfusion. While urine alkalinization with sodium bicarbonate and osmotic diuresis with mannitol can be adjuvant therapies, robust fluid resuscitation is the foundational and most critical initial step to mitigate renal damage. Question 20. A patient with a subarachnoid hemorrhage, SIADH, is on nimodipine and has a blood pressure of 140/80 mmHg. The nurse assesses the patient and notes new onset slurred speech and right-sided weakness. What is the priority nursing intervention? A. Administer a PRN dose of intravenous labetalol. B. Increase the nimodipine dose. C. Notify the physician immediately and prepare for diagnostic imaging. D. Elevate the head of the bed to 45 degrees. Answer: C. Notify the physician immediately and prepare for diagnostic imaging. This question tests your ability to recognize and prioritize interventions for a critical complication of subarachnoid hemorrhage. New onset focal neurological deficits, such as slurred speech and right-sided weakness, in a patient with SIADH are highly indicative of cerebral vasospasm. Cerebral vasospasm is a severe complication that can lead to delayed cerebral ischemia and permanent neurological deficits. The priority is to immediately notify the physician and prepare for urgent diagnostic imaging, e.g., CT angiography or transcranial Doppler, to confirm vasospasm and initiate appropriate interventions, which may include HHH therapy, hypertension, hemodilution, hypervolemia, or endovascular procedures. Question 21. A patient with an actively bleeding esophageal varices is receiving octreotide. The nurse understands the primary goal of this medication is to A. Directly constrict the bleeding varices. B. Reduce portal venous pressure. C. Inhibit gastric acid secretion. D. Increase systemic blood pressure. Answer, B. Reduce portal venous pressure. This question assesses your knowledge of the pharmacological management of bleeding esophageal varices. Octreotide is a synthetic somatostatin analog used to manage acute variceal bleeding. Its primary mechanism of action and therapeutic goal is to reduce splanchnic blood flow, which in turn significantly reduces portal venous pressure. This reduction in pressure helps to decrease the bleeding from the esophageal varices. While it has other minor effects, its main role in this context is to mitigate the elevated portal pressure causing the hemorrhage. Question 22. A patient with severe burns is admitted to the ICU. During the emergent phase, the nurse monitors for which potential electrolyte imbalance as a primary concern? A. Hypernatremia. B. Hyperkalemia. C. Hypomagnesemia. D. Hypercalcemia. Answer, B. Hyperkalemia. This question focuses on understanding the primary electrolyte disturbances in the emergent phase of severe burn injury. In the initial emergent phase, first 24 to 48 hours, after a severe burn, significant cellular damage leads to the release of large amounts of intracellular potassium into the extracellular fluid. This, combined with potential renal impairment due to hypovolemia, can rapidly cause hyperkalemia, elevated potassium. Hyperkalemia is a critical concern because it can lead to life-threatening cardiac dysrhythmias and requires immediate monitoring and management to prevent cardiac arrest. Question 23. A patient post-coronary artery bypass graft, CABG, surgery has persistent chest tube drainage of 150 milliliters per hour for the past 2 hours. The nurse also notes muffled heart tones and an increasing CVP. What is the most appropriate initial action? A. Administer a diuretic. B. Notify the surgeon immediately. C. Increase intravenous fluids. D. Prepare for pulmonary artery catheter insertion. Answer, B. Notify the surgeon immediately. This question evaluates your ability to recognize and act upon critical signs of cardiac tamponade in a post-cardiac surgery patient. Excessive chest tube drainage, typically greater than 100 milliliters per hour for 2 consecutive hours, coupled with muffled heart tones, a classic sign of fluid accumulation around the heart, and an increasing CVP, are strong indicators of cardiac tamponade. This is a surgical emergency where blood or fluid compresses the heart, severely impairing its ability to fill and pump. The most appropriate initial action is to immediately notify the surgeon, as urgent surgical intervention to relieve the pressure is usually required. Question 24. A patient with chronic obstructive pulmonary disease, COD, develops acute exacerbation. ABG results are pH 7, 32, PaCO 260 mm of mercury, HCO 334 milliequivalent/L, PaO 255 mm of mercury. The nurse interprets this as A. Uncompensated respiratory acidosis. B. Compensated metabolic alkalosis. C. Partially compensated respiratory acidosis. D. Partially compensated metabolic acidosis. Answer: C. Partially compensated respiratory acidosis. This question tests your interpretation of ABG results in the context of chronic respiratory disease with an acute worsening. The pH of 7.32 is acidic, indicating acidemia. The elevated PaCO2 of 60 mm of mercury, normal 35 to 45 mm of mercury, points to a primary respiratory acidosis, common in COPD exacerbations due to hypoventilation. The elevated HCO3 of 34 milliequivalent/L, normal 22 to 26 milliequivalent/L, indicates that the kidneys have had time to compensate for the chronic CO2 retention by retaining bicarbonate. Since the pH is still abnormal but moving towards normal, the compensation is considered partial. This patient has a partially compensated respiratory acidosis. Question 25. A critical care nurse is asked by a patient's adult child to withhold critical information about the patient's deteriorating condition, stating, "My mother can't handle bad news." The patient is awake, alert, and oriented. What is the nurse's most ethical course of action? A. Honor the family's request to reduce the patient's distress. B. Refer the family's request to the physician for a decision. C. Respect the patient's right to full information, gently informing them of their condition. D. Document the family's request and continue to provide care without disclosing the information. Answer: C. Respect the patient's right to full information, gently informing them of their condition. This question addresses a common ethical dilemma in critical care, focusing on patient autonomy and truth-telling. The most ethical course of action is to respect the patient's right to full information. Since the patient is awake, alert, and oriented, they are presumed to be competent and thus have the autonomous right to make informed decisions about their own health care. Withholding information, even with good intentions from family, undermines this fundamental right. The nurse's role is to advocate for the patient, facilitate honest communication about their condition in a sensitive manner, and provide emotional support during disclosure.